Hello all, let's begin with the chapter 2, shock and blood transfusion. So what is shock? Shock is the state of low tissue perfusion. Everybody knows that there is decreased blood supply to the cells of the body in shock, right? Because of which there is inadequate metabolisms happening in the at the cellular level. There is inadequate cellular respiration or the metabolism. There are different types of shocks like septic shock, neurogenic shock, hypovolumic shock, cardiogenic shock, right? But before going into all of those, let's just understand the pathophysiology between two major types, okay? The distributive shock and the hypovolumic shock. If you understand the basic pathophysiology between these two shocks, you will be able to answer most of the questions from this chapter. Okay, so what is hypovolumic shock? The name itself is telling us there is hypo, decreased volume of the blood. The blood volume is low. It could be because of various reasons. There is ongoing blood loss happening, or it could be because of the third space fluid loss. It could be because of severe dehydration due to vomiting or diarrhea, correct? That is the situation in hypovolumic shock. So what happens in distributive shock? Unlike the hypovolumic shock, the blood volume is normal here, but it is getting distributed at wrong places. It is getting distributed at wrong places. That is, it is getting distributed to the peripheries of the body like skin, the subcutaneous tissue, muscle, etc. And it because of the peripheral pooling of the blood is not going into the vital organs like brain, kidney, heart, correct? That is why this is called distributive shock. Now, if you understand this basic concept, you can answer the different questions that are asked on the subtypes or the various forms of this distributive shock as well. So the septic shock is also a type of distributive shock. Anaphylactic shock is also a type of distributive shock, correct? The neurogenic shock is also a type of distributive shock. Neurogenic shock is also called as the spinal shock, correct? So what happens in septic shock? There is peripheral vasodilatation because of the endotoxins released by the organisms, or the immune mediated cytokines that are released. All of these are responsible for peripheral vasodilatation. So blood is getting distributed in the periphery and it is getting pooled there. So there is no blood available for vital organs. What is anaphylactic shock? Here the peripheral vasodilatation is because of the histamine release. What is the reason for peripheral vasodilatation in neurogenic shock? It is the spinal cord injury itself will cause loss of sympathetic tone. It is the same mechanism that happens when the spinal anesthesia is given. The BP falls when spinal anesthesia is given. That is because of the same reason, that is loss of the sympathetic tone, which causes peripheral vasodilatation. Okay, now let's just see few various parameters that are changed, physiological parameters which get changed in these two shocks, distributive shock and the hypovolumic shock. Okay, so first tell me what happens to the cardiac output. What happens to the cardiac output in case of distributive shock? Is distributive shock a type of low volume circulation or a high volume circulation? Distributive shock is a type of hyperdynamic circulation. Hyperdynamic circulation, right? Be it septic shock, be it anaphylactic shock, everywhere you see hyperdynamic circulation. So the cardiac output is definitely increased. What happens if there is hypovolemia? Cardiac output decreases, right? Do you have to mug this up? No. If you understand the concept, you can answer any kind of questions asked from this. What happens to the peripheral vascular resistance in case of distributive shock? The very word distributive itself means that there is peripheral vasodilatation because of which the blood is getting distributed. Peripheral vasodilatation because of which the blood is getting distributed, correct? So what happens to the peripheral vascular resistance? Vasodilatation means vascular resistance is low. Because of pooling of the blood, peripheries would be warm or cold. Pooling of the blood means warm peripheries. Hypovolemic shock, the peripheral vascular resistance is high because the body is trying to conserve the blood, conserve whatever little amount of blood is present. So there is peripheral vasoconstriction because of which there is cold extremity. Okay, next, what happens to the mixed venous oxygen saturation? This is a very important concept. So many questions are asked from this topic. Okay, what is mixed venous oxygen saturation? Let's understand. We are basically measuring the oxygen saturation, correct? Oxygen saturation. Oxygen saturation from where? The mixed venous oxygen saturation, which means blood will come via the arteries, it will get distributed in the capillaries and then is taken up by the venous system and brought back to the heart, correct? Here in mixed venous oxygen saturation, we are measuring this oxygen in this venous blood that is returning to the heart. That is why it's called the mixed venous blood, the blood that is coming back to the heart. Mixed venous oxygen saturation. Okay, now tell me, if in distributive shock there is so much blood and oxygen getting pooled in the peripheries, what happens to the blood that is returning? There is so much oxygen available for the peripheral tissues here that they can't use so much, they will only use how much is needed. Okay, so whatever excess or whatever is pending, that is too much, it is more than 70%. That's why mixed venous oxygen saturation is more than 70% in hyperdynamic circulation. What happens in hypovolemia? Hypovolemic shock, there is no blood, there is no oxygen. So whatever little oxygen that might, if at all, reaches the peripheral circulation, that will be very rapidly used up by the cells, and hence there is nothing pending to return to the heart. So in case of hypovolemic shock, the mixed venous oxygen saturation is less than 50% and the normal value is 50 to 70%. Mixed venous oxygen saturation is more than 70% in case of distributive shock and less than 50% in case of hypovolemic shock. Lot of questions are asked from this. They can ask you the normal reference range, they can ask you the type of shock if it is less than 50%, the type of shock if it is more than 70% as well. Okay, now moving on. The hypovolemic shock and the septic shock, these two are the most commonly encountered types of shock in our surgical practice. Other than that, there are also different types of shocks like the cardiogenic shock, right? Cardiogenic, that means because of it is this type of shock is because of the failure of the heart, right? Like in case of myocardial infarction or CCF, congestive cardiac failure, or any sorts of arrhythmias, okay, or some rheumatic heart disease or some cardiomyopathy, right? Okay, now what is obstructive shock? Obstructive shock is something that you commonly see in the trauma patients, like in case of cardiac tamponade. Okay, we will study more about this in trauma chapter. Just remember the different types of different causes for obstructive shock are cardiac tamponade, tension pneumothorax, pulmonary embolism. Okay, then what are the different causes for endocrine shock? This was NEET SS 2022, that is the exam that I gave. There was this question that what are the causes for this endocrine shock. So there are two important causes. Both hypo and hyperthyroidism can cause endocrine shock. Hyperthyroidism can cause endocrine shock, and this hypothyroidism, the shock that is seen in hypothyroidism is almost similar to that of the cardiogenic shock, because there is bradycardia, decreased cardiac output, right? And hyperthyroidism will have high output cardiac failure. Hyperthyroidism will have high output cardiac failure. Then second endocrine condition that can end up in shock is the adrenal insufficiency. Also called as Addison's disease, which causes hypovolemic shock. I don't exactly remember the question that they had asked, but it was something like hypothyroidism, you know, it mimics what which endocrine shock mimics cardiogenic shock, something like that. They had asked the question, that is hypothyroidism. Remember, in hyperthyroidism it is hyperdynamic circulation, and hence it is a high output cardiac failure condition. Okay, moving on. This I have explained. Just refer to this table one more time. Okay, if you understand hypovolemia, cardiogenic, if you understand the basic concept, what is happening here, then it is very easy for you to answer what happens to these different physiological parameters. You can't keep mugging up these high low values. Okay, right. This is a very, very important table that what happens in class 1 shock, what is the volume of the blood lost in class 1 shock, class 2, class 3, class 4, less than 15%, 15 to 30%, 30 to 40%, more than 40%. I will share a separate table for this classification. There are so many other parameters also that you need to remember here. I will also list the important questions that are asked from this table in a separate video. Okay, this and this. Okay, moving on to the next topic, that how is the whenever a patient of shock arrives at the casualty, we first check the response to IV fluids, which is called dynamic fluid response. Okay, dynamic fluid response. And the question that can be asked here is how much volume of blood is used, how much volume of normal saline is used to check this dynamic fluid response. Okay, it is 250 to 500 ml IV stat is given. It is flushed, it is given very fast, over 10 to 15 minutes in the casualty. Whenever a patient of hypovolemia, say suppose a trauma patient has come to you in the casualty and you check his BP, you find that there is he has hypotension, he or she has hypotension. Now what do you do? The next step you do is you do this fluid challenge, or you check the response to IV fluids, which is called the dynamic fluid response. Okay, this is an important question, how much volume of fluid is used for dynamic fluid response. Next, what do you assess basically after giving so much IV fluid in 10 to 15 minutes? What is that you assess? See, after giving so much of the fluid, there are three things can happen. One is first category is the responders, that is patient responds to the IV fluids, and then the BP normalizes, BP becomes normal. Okay. The second category is the transient responders. Transient responders, which means because of the ongoing blood loss, initially when the fluid was given, the BP came back to normal, but because of the ongoing fluid loss, the BP eventually falls, again falls. Okay. That is transient responders. Transient means momentarily they are responding to the IV fluid challenge. Okay. Then the last category is the non-responders, because of the very severe bleeding that is happening in their body. Whatever amount of IV fluid you are giving, they are just not responding. They will require some major form of laparotomy, or they may require some inotropic or the vasopressor support. That is about dynamic fluid response. This is about regarding the monitoring of patient in case of shock. This is the table that is very important and is asked repeatedly. So what are the parameters that you assess to check systemic perfusion, and what are the parameters that you use to check the organ perfusion? Correct. To assess the systemic perfusion, that is in generally to understand if the patient is in shock or not, or if whatever fluids you are giving to the patient, is it sufficient enough to bring him back from the shock or not. What are the three things that you measure? These are the three investigations. Okay, these are not the clinically parameters. You need blood sample for this. One is the base deficit. Okay, basically we in the ICU or in the casualty, we do arterial blood gas analysis to check the lactate level and the base deficit as well, and even the oxygen saturation can be measured. Okay, what about organ perfusion? If you want to, nobody does this clinically, I mean in the routine practice, but then just for the question, multiple choice question sake, the two important clinical parameters which help us tell if the resuscitation is adequate enough or not are the urine output, which tells us the kidney perfusion, and the conscious level of the patient, which tells us the brain perfusion. Right. Now muscle perfusion is assessed by near infrared spectroscopy and the tissue oxygen electrode. Even the investigations that are available to measure the brain perfusion are same as that of the muscle perfusion investigations, that is tissue oxygen electrode and the near infrared spectroscopy. Now the sublingual capnometry, gut mucosal pH, and the laser Doppler flowmetry. There are three investigations available to check the gut perfusion. Okay, how do you remember it? All the investigations for the gut, that is gastrointestinal tract, will have something or the other related to the gastrointestinal tract. Sublingual is a the tongue is a part of GIT, right? Gut mucosal pH, gut, the name itself has got GIT in it. Laser Doppler flowmetry is something with the one word that you have to remember. Okay, one question that can be asked from this diagram. Okay, this diagram is ATC a part of trauma induced coagulopathy, or is trauma induced coagulopathy a part of ATC? Okay, ATC means acute traumatic coagulopathy, TIC means trauma induced coagulopathy. Word, the English word wise both look similar, both sound similar, correct, but then because such a diagram is given in Bailey and Love, we will have to remember that ATC causes ATC ends up in trauma induced coagulopathy. Trauma induced coagulopathy is a bigger entity here. So ATC is a part of trauma induced coagulopathy. That could be a question